Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. So welcome back to the program. This is Aebhric, and I'm talking with Dr. Edit Gara again. Welcome back.
Hi, Aebhric. It's very good to talk to you again.
So why are we going to talk about neonatal transport?
So today's topic will be neonatal transport, and I chose this topic for many reasons. One is because this population of patients has the highest vulnerability you can imagine, and I believe for this reason, this topic is extremely important to go through and to see what are the challenges, what are the hazards, how to handle a transport with a neonatal patient, to have our audience a bit prepared for this hard work. So this is the reason why I chose, and also this is a bit close to my heart, those tiny babies. That's the reason.
There's a lot of people who are listening at the moment who are critical care paramedics that do this on ground ambulances, and you've done this on ground and helicopter as well, haven't you?
So actually, I'm based in Hungary, and in Hungary, the ambulance system is organized in a way that we have a special transport unit for the neonatal patients. So it's a different group of medics with their own cars or own ambulance, own system, own equipment. And that's really important because mostly neonatal specialists are on board. And so they have hands-on experience, and they also have the equipment needed for this kind of transport. And I've done just a tiny bit on ground transport, yes. On helicopter, it's like if you have a case when a neonatal or a newborn is included, then sure, you do the transport. I don't remember any from my helicopter experience, but yes, the helicopter system, they do it as well. But actually, they don't have an incubator on the helicopter for the transport.
Before we do a deep dive on this, give me an overview on why would you, as a doctor, order a neonatal transport? Why are we doing this?
Yes, that's an important question. So when is it indicated? So this patient population is really unique. They are newborns or they are premature babies who need this neonatal transport. And in most of the cases, they are quite sick and they need some special treatment, or they need a special diagnostic such as a CT or an MR, and for those reasons they need to be transported from one hospital to another, or it's in Hungary, in Budapest, the situation is that, for example, if there's a newborn with severe hypoxia, the guidelines nowadays recommend therapeutic hypothermia, and it's only provided in one center. So those newborn babies who need therapeutic hypothermia need to be transported to that center. So these are the reasons. So like higher level care or a special diagnostic tool.
So they're just pediatric patients, right? Why are the neonatals so vulnerable?
So I would kind of differentiate them from the whole pediatric patient population, because newborn and premature babies, they are around 2 kilograms or less. They have special anatomy features, and mostly for this reason, they are extremely vulnerable. On another hand, we have many challenges facing the equipment, the transport itself. We can go through all of these today. So first let's discuss the anatomy. What are those anatomical changes in the newborn and premature babies that makes them so vulnerable? First, I would touch on the circulation, which means that these babies, the newborns and prematures, they have the physiologic shunts open, so they are not yet closed. So by the time of the birth or a couple of hours, days later on in physiologic babies, these shunts, such as the foramen ovale and the ductus arteriosus, so they close in physiologic conditions, and then there's no physiologic way to communicate between the aortic and the pulmonary circulation. But in these babies, these two shunts can remain open, and that can cause severe hypoxia in the aortic circulation as well. So this is one key anatomic difference between the other pediatrics and the neonatal group. Another one which is extremely important is that they have a really thin skin, and also they have a lack of the adipose tissue, which makes us adults and also the pediatrics to be able to regulate our temperature. So these babies are not able, they don't have the possibility to regulate the temperature, and they are really prone to hypothermia. Then the other anatomical changes include that their airway, of course, it's really small. They're prone to obstruct in response to a mild amount of fluids. And of course, they also have immature tone and immature muscles. They cannot hold their head. They cannot move. So all the mobility during the transport is really high risk for them.
They're poikilothermic, aren't they? It's a great word for their inability to maintain heat. Is that right?
That they are prone to hypothermia. Did you say just that?
So yeah, they don't have the ability to thermoregulate, do they?
Yes. That's right. And I wanted to discuss this point a bit more. So this is why we need an incubator for their transport. So most of these neonatal transport cars, transport ambulances, they have the fully equipped incubator. It's like a cot, and it's specially built for the transport. Just to give you an impression, it's around 60 centimeters long, and a baby who can fit in is of course around maximum 60 centimeters and around 6 kilograms or less. So when the baby is too big to fit into the incubator, then that's not a good circumstance for the transport. So then I would recommend to choose another way. But these really tiny babies, they fit into the incubator, and that incubator kind of acts as just the uterus of the mother. It's also often discussed that the best transport system is the mother and the uterus itself. So if something is possible to keep the baby, to just postpone a bit of birth, then that is recommended. But unfortunately, in many cases, the incubator is needed. So in terms of the hypothermia, the guidelines recommend minimal handling throughout the transport, meaning never open the incubator unnecessary. So try to minimize any handling. The incubator has a large door to open, and also has just two tiny holes just to put your hands inside if you need to manage an equipment. But you can imagine that you have a 60 centimeters incubator. It's not really easy to observe the patient. It's not easy to recognize if there's some failure with the equipment or with the airway, if there's suction is needed. Mostly the eyes of these tiny babies are closed and taped and handled because they are really, really sensitive for light as well. Coming back to the hypothermia, it's really important to keep these babies in these incubators as much as possible.
That's a profound challenge on top of just transporting a critical casualty. Now you're transporting a casualty and you can't touch them. That's pretty difficult.
Yeah. Actually, you can if you must, but in any other cases, it's unnecessary to avoid. It's also recommended to put textiles or even a hat on the newborns or on the babies. And regarding the equipment, there are also special heating mattresses which can be put under the babies, and it can also help to regulate their temperature. Just to bring one example, you mentioned you can't touch them. Yeah, and it's right, and even it's not recommended to handle any equipment during the transport in movement. I mean, if you need to regulate the infusion pump, or if you need to change the infusion pump, the medication, or you need to start a new medication, then it's recommended to stop over in a calm environment and do everything in a stopped car, and then continue your way, because that's the safest way to do.
You would pull over, stop the vehicle, and then you would do these.
Yeah. If it's not, I mean, if it's a transport for a diagnostic tool for CT or MI, yes, I would definitely stop. If it's really time sensitive for any reason, maybe it's a transport for a therapeutic hypothermia in a hypoxic baby, then of course you would try to do it as quick as possible. But it's also, I wanted to mention that you just cannot go with these babies high speed, because the quality of the roads are not so good. They are really extremely sensitive for the vibration and for the acceleration as well. So if you see an ambulance with the sirens on and just moving with very, very low speed, it might be a neonatal transport, because the technicians driving the cars are trained to avoid any unnecessary movement, any unnecessary turns. They try to manage the softest way as possible. So I mentioned the vibration and the acceleration. And imagine, I've found studies that both vibration and acceleration, they increase the risk of an intracerebral hemorrhage in a premature baby.
How does that work? How does it increase the risk?
Yeah, so because in terms of the acceleration, on one hand, there is a direct movement of the body of the baby itself. Of course, the incubator is safe and you have a safe environment, but still there's tiny movement. And on the other hand, there's the movement of the blood within the blood vessels. And if there's a speed increase or a speed decrease, then the tiny immature vessels within the brain, they can simply suffer damage from this tiny force, and studies prove this.
Wow.
So it's kind of not allowed to give a quick speed increase with the neonatal transport. So it's kind of an art, to do a neonatal transport. And also the vibration, so the quality of the roads, the engines of the vehicles, they themselves generate a vibration. It increases the discomfort of the baby. So the best is a slow, soft, continuously moving ambulance.
The baby doesn't have restraining belts on it, does it? You're not putting seat belts on him. How are you keeping it safe?
So it could be a vacuum mattress, which is formed like a net, and it's formed around the baby to minimize the movement of the body, but no seat belts, no belts.
And then would you elevate the head?
No. I would recommend just a flat, neutral position for these premature and newborn babies.
So even if a slight acceleration or bump would increase
Yeah.
the ICP of the head, why wouldn't you elevate the head to minimize that risk?
So yeah, because the position of the endotracheal tube and all the ventilatory circulatory equipment, the best is if it's in a neutral position. And there was no advantage of an elevated head to decrease the risk of an intracerebral bleed.
Interesting. And oxygen are you giving?
Yeah.
Are they on a vent or what? How are you transporting them?
Yeah, thanks for this question, because it's really a key point to discuss. Because so how can you administer oxygen? How do you ventilate them? Is oxygen a good guy, a bad guy? So yeah, it's a deep question. So first of all, I would recommend to deeply discuss the way, the route, the amount, the frequency, and everything about oxygen before the transport with a neonatal specialist, because too much oxygen harms these tiny babies. So hyperoxemia is extremely dangerous in this population. The reason is because they respond to increased levels of oxygen with a constriction of the vessels. And this kind of vasoconstriction first happens in the pulmonary circulation, and then it can happen in the intracranial circulation, and then in the periphery as well. And it's just dangerous. It causes increased pulmonary tension, and again, for their whole premature system, it's dangerous. So try to avoid hyperoxemia. And for this reason, these ambulance cars, they do not only have oxygen tanks, but they have normal air tanks as well. So it's possible to administer normal air into the incubator. How can you do it, or how does the ventilation of these tiny premature babies work? So there's special equipment which is called an NCPAP, meaning a nasal continuous positive airway pressure ventilation. So it's a nasal equipment providing continuous pressure support to their breathing. Another way is a smoother way is a high flow nasal cannula, which is also designed only for this patient population. And if there's a need of higher airway support, then of course an endotracheal intubation and ventilation. I would also like to outline that there's a need to humidify the whole system and the whole gases and circulatory, the ventilatory circulation for these babies. And it's a special equipment again. Mostly it's called the neopod, which is used. The neopod, it's a humidifier, and it can heat a bit the oxygen or the air which is administered.
So you can't give them ET tube with a cuff, can you? So you're just doing a CPAP basically. You're not doing synchronized ventilations.
Yes. So basically, the first line to choose it's a CPAP. You can also provide pressure support with a synchronized mode as well, and you can also use an end-tidal CO2 measurement. So you also there's also special equipment for these tiny ventilatory systems.
You're switching between oxygen and then room air.
Mm-hmm.
Are you basing this off of their pulse oximetry reading?
So yes, and yeah, again, I would study like their first 24 hours or the 24 hours before the transport, and see how they went, how much oxygen they required. And it's important to have a plan in terms of the oxygen support for the transport. And also it's always their oxygenation is a bit always worsening during the transport, so you can count on that you will need to increase the amount of oxygen delivered. And yes, you can continuously monitor their saturation levels. If there's so some of these premature babies have severe congenital heart disease. That's extremely complex and hard case, and for those babies, the oxygenation, the saturation measurements can be tricky. And for those, I would recommend to transport them with neonatal specialists, and maybe with neonatal cardiologists as well, to be able to fully control their state. It's also important to discuss that with the newborns, they might have low oxygen saturation levels in the first 10 or 15 minutes, even when they are completely healthy. So within those time, or if you happen to have to have a birth in a remote condition or in a pre-hospital situation, so those first 10-15 minutes, I would rather focus on the heartbeat. And if the heartbeat is okay, then I would not really bother if the saturation is a bit low in the first 10 minutes. So for adults, it depends which kind of patient population. Lots of them are having COPD. We also know that hyperoxemia is harmful in ST segment elevation infarct patients. So careful with oxygen.
So when you have a neonate on high flow oxygen, CPAP, is there a risk of blowing off all the nitrogen as well and collapsing their lungs?
Yeah, so of course they are at risk of barotrauma or at risk of trauma with the ventilation. But it's not it doesn't happen that often. I can't remember any. Yeah, there must be cases, but PTX during transport, it's not so frequent. So again, discuss with the neonatal specialist if the baby is an endotracheal tube, which would be the ideal parameters for the ventilation. And I would say that it's harder to cause them trauma with the ventilation than in the adults, because also their tissue are a bit more not so rigid, not so fragile. But we have to take care in that term as well.
So there's a lot of variables and a lot of risk with the oxygen and the CPAP machines and the ventilators. What other dangers outside of the airway and breathing issues will you see with a neonate transport?
So one I would outline, and it's again related to their premature system and the premature physiology, is that they are extremely prone to hypoglycemia. So just right before the transport, it's recommended to have a blood sugar measurement and to correct as needed. Other dangers, which I would outline, they are kind of related to the transport itself. So we already discussed the temperature, we discussed the vibration and the acceleration. We haven't touched on the noise and the light. They are extremely sensitive. to the general noise. For example, the loud speaking of the medics within the ambulance, the siren, which is an extreme noise. Also, if there's an air transport, it's an extreme noise. So it's recommended to put on a protective device on the ears. And if not extremely necessary, then try to avoid any other noise, any loud speaking. Their neuronal system, the brain, is really mature, and again, it can be really harmful, painful, or really hard discomfort for them. And another thing that I would like to mention, which it's kind of a danger as well, that the mother and the father, the family, is not always able to be around the transport. And the care of this population is the best if the family is integrated. So it's always recommended to try to do it during the transport as well. So if it's possible, then try to let the mother within the ambulance and let the mother travel with the baby. Mostly it's not possible because of the condition of the baby is not allowing it, not enough space, etc. But again, the parents are mostly presented within the unit, within the department at the hospital. So let them see how the baby is prepared for the transport. Always talk through them what is happening, what will happen during the transport, what will happen when they arrive. And it's a good way to try to, if there's a picture of the mother, it can be on the incubator, even when the baby is not able to see it. And it's also good for the mother to have a picture of the baby. So the family integration is a key.
I can imagine it gets quite cramped in the back, especially if you have a cardiologist as well as a neonate specialist, and not a lot of room for family.
Yeah, that's right. But still, it's extremely important to involve them as much as possible.
So, what is the longest time you've commuted with a neonate transport?
Not so long. So I've just done it within the city, and there's not so much, not so long transport. But I've have colleagues who've transported from one side from the country to another, and it could take up hours. So during that time, it's extremely important to keep all the functions of the baby well. And the feeding is again really, really tricky. As I've just mentioned, they are prone to hypoglycemia. There are feeding tables, how much fluid they need per day, and they need extremely tiny amounts, like 50, 60 milliliters in 24 hours for an extremely premature baby. And of course, you have to administer those with infusion pumps. If possible, the baby can receive milk from the mother as well. I would not recommend to do that during the transport, but again, the family integration is key. There's
a lot of challenges in that.
Yeah, how much experience you have, or have you had, what is in your experience, a newborn or a premature one, or birth in pre-hospital field?
There's a lot of medics out listening to the podcast. What suggestion would you have for them as they approach their first neonatal transport?
So I would recommend to prepare really, really hard, because it's extremely challenging, and you don't have room to move around. You don't have a good circumstance for the observation. Speak to all the specialists you can. So just plan and prepare. And then again, if it's not so time sensitive, then it's better to step over, to rethink again everything. It's even not easy to examine the baby within the incubator or without opening the incubator, but go through ABCD as many times as you need. They can change in seconds in this population. So plan and prepare and know your equipment very well.
So my last question for you is, where can these medics go who are interested to learn more about neonatal transport? Where is a good place to learn?
So I would recommend that first go to neonatal wards because you can gain some hands-on experience there. So because the transport itself is just so vulnerable state, or it's just so a sensitive period of time, it's not the best place to get the first experiences. But on a ward, you can learn a lot, and then if there's a neonatal unit, a neonatal ambulance around, then go there, try to do a secondment and see how these tiny babies are handled.
It's a good idea. So you have a little bit of experience with a neonate before you get them in the back of your ambulance.
Yes. You have to have, because otherwise it's they are just so vulnerable and so special patient population that you have to have some experience before.
That's fantastic. I definitely appreciate your deep dive into neonatal transport this week.
I hope I could share some of my experience and knowledge with the audience, and I hope you liked it and you could learn a bit from it.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, COROM, corum.org.